Next is CMI, chronic mesenteric ischemia, very important topic for us. So how would a patient with chronic mesenteric ischemia present? If it's in the clinic, she will be hectic lady, long history of smoking, abdominal pain, and weight loss because of the fear of the food, and the pain is dull or colicky in the epigastrium, go in radiate into the back, start 15 to 20 minutes, 30 minutes after the eating, and remains 3 to 4 or 1 to 3 hours postprandial. And on physical examination, you have to examine universally, but specifically you have to examine her regarding the signs of vascular disease, carotid bruit, peripheral vascular disease, and present abdominal bruit may be present but are non-specific. What investigation would you request in a 45-year-old male, female with symptom of CMI? So first of all, I will request ultrasound scan to rule out gallstone, then I will do CT scan to rule out intra-abdominal malignancy of the mass, and then I will do specifically CT angiography or mesenteric resonance angiography, and catheter-based digital subtraction angiography is the gold standard. And how will you treat the mesenteric occlusive disease? So two options are here: open surgery and endovascular surgery. Endovascular surgery has less morbidity, but it has high recurrent stenosis or thrombosis. And open surgery, there is options of antegrade supracilic bypass and retrograde infrarenal or common iliac artery bypass, and then end arterectomy and reimplantation of affected vessels. If you are considering an open procedure, what type of conduit would you use? If I'm not worried about the infection, I would use the prosthetic conduit, but if there is a chance of infection, I will use autogenous conduit. What is the median arcuate ligament? It is the median arcuate ligament of the diaphragm which compresses on the celiac axis, and this can lead to the reduced flow, chronic abdominal pain, and mesenteric ischemia. Unless the SMA is diseased, it should provide sufficient collateral flow on the obvious symptom, and the treatment is open or laparoscopic division of the ligament in the definitive treatment. And during the workup for this 45-year-old female, she developed severe constant abdominal pain with a raised white cell count and elected. How will you manage her? So I'm concerned. I will admit her. I will resuscitate her in the form of IV fluid, oxygen, analgesia, and request CTA. And I would perform a middle laparotomy, assess the bowel, and attempt revascularization. And a retrograde bypass with autogenous conduit is a safer approach in an unwell patient and potentially soiled field. Thank you.